Perfect. Thank you.
Right. So I am based at Guy's and St. Thomas's Hospital. And Guy's and St. Thomas's Hospital is two hospitals based on two different sites. Just one moment, I'm just going to narrow my video here because it's yeah. So Guy's is based on very close to the London Bridge on the left here, and then the Tower Bridge there. And St. Thomas's is opposite the Houses of Parliament. So if you're visiting, just be mindful. I've had people traveling and then they end up in St. Thomas's and they'll be looking for where the clinic is, but we are up here at Guy's Hospital. I snatched this is a screenshot of your questions here, Jay, showing the commonest causes of tracheal stenosis. It's intubation. It is the same thing for glottic stenosis as well, the posterior glottic stenosis. And actually, this is underreported, and also a lot of patients do not present with mild symptoms. But the incidence is actually it's more than 10 to 20% that is reported in the literature. And I have the feeling lots of these reports are from possibly ENT. There are lots of patients that have had intubation that they come back for anesthetic follow-up in their clinics. And we've noticed during the COVID pandemic, so many patients were eventually referred by their GPs because of ongoing breathing difficulty. This is after they've gone to see the sleep physicians and the respiratory physicians, and they were treated for asthma and not getting better, and eventually they end up in our clinics. Very few patients were referred to us by the anesthetic or the intensivist after their clinic, and they were reassured that things were going to settle down. But for some patients, it doesn't. And the relevant to that is that shortness of breath or stridor can really, really impair on the patient's quality of life. Not just for the breathing, but physical activities, sometimes even eating and changes in the voice can be affected. So we know the effect of pressure on tissues, how it results into ulceration, then fibrosis, and this is how comes we develop the stenosis. The curve pressure, it's important, and prolonged intubation is important. The size, traumatic intubation, and any infection, and comorbidities. But the one thing that I have observed that have not been picked about much is the size of the tube. And I was chatting to my anesthetist and I said, what's the standard size that you use? And he said to me, 8. But the question is, do you need size 8, really? Because in my airway, the laryngotracheal stenosis, the most complex one is the posterior glottic stenosis. This type of injury not only affects the patient's breathing, but it can affect the voice. And the treatment outcome can affect the swallowing because you have to widen the posterior glottis, an area that is already in a fixed position. So there is a risk of aspiration. So I find the posterior glottic stenosis is the most challenging in adults. Of course, in children, the approach is slightly different. You can do rib graft there. In adults, it's a different situation. So investigate the diagnosis from the history. You can make the diagnosis, history of intubation. You know that most likely is related to it will be the cause of the problem. When I was a young laryngologist, I have seen a lot of post-intubation patients with bilateral vocal cord immobility. I am still young there, by the way, so just in case you're thinking, oh, he's not too old. You're correct, I'm not too old yet. But when I was much, much younger, I've been referred patients so many times with bilateral vocal cord immobility as paralysis. And during the COVID pandemic, it's really opened my eyes because Until proven otherwise, any patient that comes with vocal cord immobility after intubation is due to cricoarytenoid joint immobility. Until proven otherwise, that will be the cause of it. We've done lots of laryngeal electromyography, and these patients, they all have normal signals. When we take them to the theater, we have a good look, we see scar tissue, such that now we can actually see the scar tissue much easily in the clinic. The trachea is easy to assess. All you need to do is to numb the vocal cord, and then you can see the entire trachea. So I do not need CT scan to diagnose tracheal stenosis. So this is just a local anesthetic into the glottis, and you'll see the entire tracheobronchial tree. So you do not need a CT scan to make a diagnosis of subglottic or tracheal stenosis. You have a very good information, even the thickness of the glottic narrowing here. By the way, this glottic scar is not from intubation. This was just some other procedure. Somebody did some surgery and then damaged the anterior glottic web. So I'm putting some stent there. But I've put this just to show you that you can do tracheoscopy easily in the clinic. So the management depends on the site. But the principles is that you need to restore an airway and preserve laryngeal function with minimal effects on voice and swallowing. There are two approaches. Most cases, especially the mild to moderate cases, can be managed endoscopic, and this is the theme of my talk today. Again, this morning I was listening to one of the anesthetists who gave a fantastic talk today about intubation and access to airway. And I picked on this, and this is what one of his slides showed: standard tracheal tube. Can you see that, the cricoarytenoid joint, how it is completely splinted? So remember, the cricoarytenoid joint is a synovial joint. It's like your wrist or your elbow or your knee. So if you leave it splintered for a few hours, you feel stiff overnight. You start to have prolonged stiffness. So posterior glottic stenosis is the most commonest damage from intubation, because the intubation tube is very firm. It's not like the curve. So if you leave the tube for so long, you get injury. I would rather have a tracheostomy inserted in me if I were a patient. If I'm going to be in the, God forbid, but if I'm going to be admitted in the intensive care units, I do not want the tube more than 24 hours. I would rather have a tracheostomy tube and then take it out when I'm ready to be extubated, because tracheal granulation is easier to deal with. Even airframe trachea is easier to deal with than a complete posterior glottic stenosis, which will completely knock out your voice as well as the airway, and the recurrence is very high as well. So lots of my talk here, I'm going to focus on the posterior glottic stenosis. Posterior glottic stenosis, there's a very good classification here, the Bogdasarian classification, which is type 1, type 2, type 3, type 4. So type 1 is the interarytenoid scar, like a band of scar, but the arytenoid is mobile. Type 2 is scarring of the posterior interarytenoid mucosa or musculature leading to fixation of the cricoarytenoid joint, but preserve mobility of the vocal process. And type 3, unilateral cricoarytenoid joint fixation. And type 4, bilateral cricoarytenoid joint fixation. It is very difficult to treat such cases, and recurrence is very high. There is also subglottic stenosis, which probably is easier to manage endoscopically. All you need to do is to make the cruciate incision with the laser, steroid, and then balloon dilatation. Although in very thick, dense scar, recurrence rate is quite high, but endoscopic approach is not a complex problem. And also, once you sort it out, the voice is not affected, the swallowing is not affected. So is the tracheal stenosis as well. But the posterior glottic stenosis, this is where you have problems with the voice and then the swallow that can impact on the patient. So tracheal stenosis, normally you classify it by the length and the location. The endoscopic techniques consist of balloon dilatation, laser, cold still. You may use topical mitomycin or steroids. I don't use mitomycin C, not because it doesn't work, but I have no experience in that when I was training, so I didn't start using it. And I had some stories about controversies about it. So I use Kenalog or Depamedron. Normally, I will have combination of balloon, laser, and sometimes even cold steel incision. The laser normally is to guide the balloon dilatation, but sometimes in the very dense scar, you may need to cut it out. So the role of stents, again, in palliative cases, and sometimes you can put temporary stents such as silicone stents. Be mindful that you may have problem with granulation and migration and infection. So the outcome of endoscopic treatment can be very, very effective in selected cases. Don't be ashamed of yourself if you have recurrence. It's normal to have recurrence in some cases. You need to take the patient back to theater and then do that again. So surgery remains the gold standard in these cases. In complex cases, you may need to go external approach. So when I list a patient for an endoscopic management of posterior glottic stenosis, this is what I write on the consent form. I put everything there because quite often I go in there and I see things that I didn't see in the clinic. So my approach can change intraoperatively. So I warn the patients about all these steps and what it entails. I am fond of doing lateralization suture. You can do endolaryngeal approach or external. So for the endolaryngeal, you use Lichtenberger needle, as you can see here. So this is a double-ended needle. You have the Lichtenberger trocar to deliver the needle, and I will show you example. For the external approach, you can use a 21G needle, and you can insert the stitches via that. There is a nice demonstration here by Marcus Hess on the cadaver. So this is how the external approach looks like. You lateralize the vocal cord or the vocal process that way. So let's see some cases here. So this was a patient of mine during the COVID pandemic who was intubated, and the patient had posterior glottic stenosis. So you're going to see that this is a type 2 because the scar band tissue there goes between the two vocal cords. The arytenoids were mobile. Let's play that video now. So you can see here. So you can see the space here. So the scar band tissue is mainly between the vocal cords, posterior end. So I did laser to remove them. Now, because I wasn't 100% certain that there is no scar deeper, I will have to double check again the mobility and use cold steel knife to palpate. And if there's any tough scar tissue there, I will cut it. But of course, if I leave it like this, the chances is that it's just going to retract and close again very quickly. So in this case, I do lateralization suture. So I laser the thyroarytenoid muscles lateral to the vocal process. I inject steroids, Kenalog steroids around the joint here, and then use balloon to stretch it to widen the glottis. When I take it out, you see it collapses back again. So I need something to keep it laterally. And in such case, I use the lateralization suture. And this is the Lichtenberger needle. As you can see, you deliver from below the vocal process and above the vocal process, and you stitch it from outside like that. Yeah, that's it. So this is it going on, and you stitch it from the skin from outside. Normally, I put 2 stitches because in case one slipped, you have another one holding it in place. So let's look at the video before and after. So this is before.
3.
So you can see in clinic, you don't see much. But in these patients, you need to look down into the trachea. So by putting local anesthetic, anesthetizing it, you can easily go into the trachea and then examine the posterior glottis. So you can see the scar band tissue here. And this is post-op, so you can see how widely it is. So you can see the movement of the vocal cords is partially restored. Let's look at another example again. So with this one here, you can see the scar tissue on the right side here. Quite often, sometimes it's more than one pathology. This patient has got airframe trachea. So if you look at the history here, the patient was intubated, had tracheostomy, which is responsible for the airframe deformity. So I'm just lasering the dense scar tissue because this patient had this injury since he was a child. So the tissue is very, very stiff and matured already. There is no amount of just balloon dilatation that will resolve this. You have to remove and excise the tissue and inject steroids there. And this is after removing that, that's the steroids going into the scar tissue. And I use trachelator, which is a fantastic balloon because it has space there. The patient can breathe through that. You don't need to stop the ventilation. So this is the airframe trachea I'm excising. You can see it over there. So there are times whereby you do not need open approach to sort out an airframe tracheal deformity. And this is what it looks like post-operatively. So let's look at some more examples again. This is another patient. This is type 4. Type 4 Bogdasarian is more complex because the crack or retinoid joint is fixed on both sides. So in such cases, I throw everything at it. So this is beforehand. Yeah. And let's look at intraoperatively. So you can see here, the vocal process, the retinoids, it's not moving at all. So injecting some steroids there, and then use cold steel, cut through the scar tissues, and then use balloon to dilate it, just to out-fracture the crack or retinoid joint, and then cut some more scar tissues there. But if you leave it, it will just close straight away. So I had to put the Lichtenberger lateralization suture, as you can see on the video there. So this patient, the breathing was better, but was not perfect. I did only one side, so you can see it's quite a big space I've created. But even after that, the patient felt that they could do with a bit more. So I had to revise this and took the patient back to theater and to the opposite side. So this was the video. Post-op, you can see the crenulation reforming around the area. And this patient has since had a revision surgery and was fine after that. There are times whereby you may need to do partial medial arytenoidectomy because if you cannot lateralize the vocal process, you cannot remove sufficient scar tissue there, then you may need to do partial medial arytenoidectomy. I must admit, I don't do chordectomy or cordotomy because I don't find it useful. If cordotomy works, probably this patient doesn't need the procedure to begin with. And also, you may have to take a lot of the vocal cord if you want to do just chordectomy. So in this case, I remove, say, a third of the vocal process and create a space like that. Again, this patient was intubated and had bilateral immobility of the vocal cord. Let's look at a video before and after.
3, 4, 5.
So you can see some stridor there. And this is after the procedure. Voice is affected as well. So this is our setup. We now use tubeless ventilation using twin stream. This is my fellow Adam operating a couple of weeks ago. You can see the setup there for the partial medial adductomy. This is CO2 laser, but you can use KTP or blue laser. It cuts equally. This is some procedure towards the end of it. Subglottic stenosis, I don't come across a lot of it from intubation. For this particular patient is idiopathic, but I just put the video here because the approach for the treatment is similar. You make laser, cruciate incision. There's a description of Mercedes-Benz incision, but not all stenosis are circumferential. You can have multi-level stenosis. So you just cut where the scars are and then inject steroids and balloon dilatation, as you can see in this case. Sometimes we do this in the office, especially the airframe trachea, because we have the trachelator. We can do that with the patient spontaneously breathing, like in this case. So this is a patient with airframe trachea. You can see there's a granulation tissue here, airframe trachea. So I did 2 stages. The first stage I excise. So you have to be careful not to go too deep, otherwise you're gonna have, you can laser into the mediastinum. Again, we did this last year. That was my fellow during the procedure. I was busy taking a video during it. The music in the background is for the patient. We normally give verbal anesthesia for the patient and some comfort as well. When the patient chooses the music they want to listen, just to distract them. And after that, I use the trachelator, balloon dilatation. You can see the trachelator. So the patient is breathing. You can keep that balloon for as long as you want. Saturation. So we're monitoring the patient's vital signs at the same time. And this is what it looks like. And the patient returns a month or 2 later for completion on the other side as well. Again, tracheal granulation, you can do that in the office. This is the tracheal granulation following tracheostomy. There's tracheostomy in situ there. You can see we use blue laser there. And this is it. And this is the patient 2 months after. It's all clean. Again, there are patients that are not well enough for general anesthetic. So we'll do that in the office. Again, tracheal granulation on this patient here. Just going to show you quickly and fast forwarding because of time. Again, lots of tracheal granulation here. And this is it after. So you can have bleeding, airway perforation can be an issue. The granulation can reoccur. You may have re-stenosis again. But endoscopic management is safe. It is minimally invasive. And a lot of patients, it is the first line of treatment. And just be mindful of the patient selection. Also, you need to liaise with your thoracic and respiratory team as well. Just don't forget there is the BLA meeting coming on the 3rd of October. If you haven't reserved your place, feel free to do that now. We also run multiple courses, all you need to know about laryngology. And we've added a new course here on hands-on dissection on OSA as well. So book your place now. Thank you very much.
That's great. Fantastic. We'll take some 2 questions, then we can rest. We can type in terms of time. So when you use a balloon near arytenoid joint, aren't you worried about dislocation?
Actually, I would love to have dislocation of the joint because the joint is fixed. It's useless. It's not doing anything. It's fixed in the medium position, and that's why the patient is having the stridor. So I would like to push it out
Good.
to stay in the lateral position.
And
So no, I'm not worried about that.
which suture material do you use? Size? How long does it in place?
So 3-O proline, I'll keep it for 4 weeks.
How do you manage post-operative aspiration following a retinoidectomy? How do you manage it? Does the patient need?
Yeah, I can nasogastric tube and kneel by mouth and until they're safe to swallow again. And then I've not had any single patient that's had any permanent aspiration or PEG or anything like that. They've all been decannulated. NG tube have all been removed. Usually, the first day or two, because of pain, they may need nasogastric tube feeding. So most patients, the first week, you can take it out.
Brilliant. That's fantastic. I think that's all the questions. Thank you, Mr. Karagama, and awesome talk.
Thank you.
Next is we have